Okay, so today we're gonna cover pediatrics. So neonate who's between 0 to 3 months old and they have signs of infection. What are the most common bugs? They are group B strep, E. coli, and listeria, and that spells out bell. And most of the time in a fever or infection of someone less than 3 months old, you should suspect either pneumonia or meningitis. And so you will treat with ampicillin or gentamicin to cover group B strep, E. coli, and listeria. Once they're older than 3 months, then you will switch to the most common causes of bacterial meningitis and pneumonia, which are strep pneumo, H. flu, and Moraxella. And then with those ones, you want to give the empiric antibiotics of vancomycin and ceftriaxone. Again, any neonate who's less than 28 days old with a fever must be hospitalized for safety and for a workup. In terms of CSF findings, remember that you should know the difference between bacterial, viral, and fungal CSF findings. So bacterial CSF will have elevated protein and then decreased glucose because the bacteria will consume the glucose, and then elevated white blood cells but neutrophil predominant. Whereas viral will be normal glucose levels, elevated protein, but elevated white blood cells but lymphocyte predominant. And then the last is fungal, and fungal infections are what I think of like in between. They're kind of like a mix of bacteria and viral. So then what will happen is that there will be low glucose, but it will be lymphocyte predominant. And remember that TB is one of those strange bacteria that kind of has fungal type of labs. So it'll also have lymphocyte predominant CSF with low glucose, and TB is kind of the exception. And then remember, fungal meningitis is more common in immunocompromised patients, and the classic is the AIDS patient who has Cryptococcus neoformans, which will have positive India ink stain. And then you want to treat that with amphotericin. Some key associations is that TB meningitis will have basilar enhancement on brain imaging, whereas HSV meningitis has involvements of the temporal lobe as well as seizures. In terms of sinusitis, the majority of sinusitis is actually viral, and with viral sinusitis, you want to treat it with supportive care. But in terms of bacterial sinusitis, signs of bacterial sinusitis are if it's been over a week and it's worsening and not improving, and on top of that, the nasal discharge will be purulent. So if it's purulent and it's been over a week and it's not improving, that's more bacterial sinusitis. So you want to treat that with antibiotics, mainly amoxicillin, and you want to cover the most common bugs, which are strep pneumo, H. flu, and Moraxella. Remember, strep pneumo, H. flu, and Moraxella are the most common for sinusitis, for pneumonia, and for acute otitis media. It's also very common for meningitis, but for meningitis, the third most common instead of Moraxella is actually Neisseria meningitis. Yeah, and then sometimes bacterial sinusitis can progress to something more dangerous where it can start invading your venous sinuses. It can irritate the nerves, like your cranial nerves 3, 4, V1, V2, and 6, and so you'll have like blurry vision or double vision. At that point, if it seems to be progressing beyond just the sinuses and it seems to be getting worse, and that's when you want to do a CT sinus. Remember that for an upper respiratory tract infection, most of them are also viral too. To diagnose it, it's mostly diagnosis of exclusion. It'll present with cough, runny nose, sore throat, but not necessarily a fever. And then for those, it's supportive care. And the most important thing in kids is just adequate hydration. Diphtheria is seen with the pharyngitis with the gray leathery plaque in the pharynx. It's seen in vignettes where the kid has no history of DTaP vaccine. And then you want to treat that with diphtheria antitoxin. Acute otitis media is also a very common pediatric infection, and this will be seen with otoscopy. You'll see bulging erythematous tympanic membrane, and on pneumatic insufflation, which means when you blow air against the eardrum, it'll be very stiff. This will have fever and ear pain. The main way to diagnose is just by the otoscopy findings. You want to treat that as well with amoxicillin. You have to be able to distinguish this from otitis externa. The key here is otitis externa. The eardrum will be fine. It's the ear canal which is inflamed and infected. And the key thing here is with otitis externa, it hurts with ear pulling, whereas in acute otitis media, ear pulling actually improves the pain. A kid with otitis externa, when they pull their ear, it hurts a lot, so they won't even let you do that. And the number one bug for that is Pseudomonas, and you treat that with antibiotic ear drops. And then the third type of ear infection is otitis media with effusion, which is where you kind of see like a serous drainage in the middle ear, but the middle ear itself isn't infected. There's just fluid in the middle ear which isn't draining. And on otoscopy, you'll see little fluid bubbles behind the tympanic membrane, and you don't treat that. You just let it pass. And then there's cervical lymphadenitis, which is a lymph node that is erythematous and painful and swollen. And if you see a lymph node that is infected, it's most likely Staph aureus, and you want to treat that with either first-gen cephalosporin or penicillin. It's important to know the difference between parotitis that's unilateral versus bilateral. If it's bilateral, it's most likely mumps. Mumps is a viral infection that can be protected with the MMRV vaccine. So kids who don't have the MMR or MMRV vaccine will have mumps, and that causes bilateral parotitis. It causes meningitis. It can also cause pancreatitis, and it can also cause orchitis, which is inflammation of the testicles. If it's unilateral parotitis, then the most common answer would be Staph aureus. Impetigo is where you'll have a vignette with the kid who has like a honey crusted lesion around his mouth, or it can be anywhere on the skin. A lot of times it is around the mouth though. And then this is extremely contagious, and first line treatment for impetigo is mupirocin. You should also know the difference between erysipelas and cellulitis. So erysipelas and cellulitis are both most commonly caused by strep pyogenes, but they like to test you to see if you know the difference. And the two main differences are that erysipelas has a very rapid onset, so it'll happen over the course of a day, and its borders are well demarcated. It has sharp lines where it goes from red to normal skin. It'll be very sharp borders. This is a dermal lymphatic infection, whereas cellulitis is an infection within the dermis, and this has more indolent increase. It gets more and more red over a couple days, and the borders are kind of indistinct. So basically from red to normal skin, it's more of like a soft gradient. Yeah, and then you also treat those with either a cephalosporin or a penicillin. And then necrotizing fasciitis, the two most common culprits are strep pyogenes and Clostridium perfringens. And then this is the one where it's severe pain out of proportion. You'll have some sort of skin wound, and it looks kind of red, but as soon as you touch it, they're like screaming in pain. So it's severe pain out of proportion from what you would expect. You might even see hemorrhagic bullae. And if there is crepitus, which means like there's gas bubbles, then go with C. perfringens, because C. perfringens creates gas bubbles. If no crepitus, then go with strep pyogenes. So next is scarlet fever. Scarlet fever, just think of the combination of strep throat plus a sandpaper rash. That's all you need to know. And then the rash usually starts on the trunk and spreads to the limbs. Post-strep glomerulonephritis, PSGN, you need to know the difference between this and IgA nephropathy. So post-strep glomerulonephritis starts off with strep throat, and then 2 weeks later, the kid will complain of cola-colored urine, which is due to hematuria. And this is actually glomerular bleeding. So you'll see red blood cell casts and dysmorphic red blood cells. And the key thing here between this and IgA nephropathy is the timing. So PSGN will happen around 2 weeks later after the throat infection, whereas IgA nephropathy happens within like 3 to 5 days, definitely under a week. So timing is key. And IgA nephropathy actually follows an upper respiratory tract infection, not necessarily strep throat. It can be confusing because they both involve upper infections and they both have hematuria, but the timing is key. You should know about toxic shock syndrome, caused most likely by Staph aureus, and in the history, there will be either a kid who had a nosebleed who was packing it with paper, tissue papers for too long, or a female who has had a tampon in for too long. And this leads to septic shock because the Staph aureus exotoxin actually stimulates the T cells to release a lot of cytokines. So you'll have shock with desquamation of the skin. So you want to treat that by giving fluids, antibiotics, and then removing the tampon or the tissue. The two most common causes of gastroenteritis are rotavirus and Norwalk virus. So rotavirus is more in the winter months and it has vomiting and diarrhea, but this is kind of self-limited, so you want to treat it supportively. Remember that this type of diarrhea is not inflammatory diarrhea, so there's no bloody stools and there's no white blood cells in the stool. And then Norwalk virus is also a non-bloody diarrhea, and it also has vomiting and diarrhea. But the key here is that it occurs a lot in daycares, in schools, and cruise ships. Both Rota and Norwalk virus are associated with these locations, which should be hints for you. So then there's the inflammatory diarrheas, which are Campylobacter, enterohemorrhagic E. coli, EHEC, Salmonella, Shigella, and Yersinia. All of these are inflammatory diarrheas, which means that they have bloody diarrhea. The stool analysis, which is the first thing you want to do, will show white blood cells in them, which indicates inflammatory diarrhea, and they might also have fevers as well. So some key associations is that Shigella can cause seizures. Yersinia can mimic right lower quadrant pain, which can mimic appendicitis. Campylobacter is associated with eating raw chicken. And then Salmonella is associated with being around reptilian animals or like eggshells or like being at the zoo. EHEC is associated with eating uncooked hamburgers, patties. And then these all cause inflammatory diarrheas. And then the last diarrhea I want you to know about is C. diff, Clostridium difficile, which is associated with taking broad spectrum antibiotics. And then this leads to opportunistic infection of C. diff, which colonizes your intestine and colon, and it can cause something on colonoscopy which can reveal pseudomembranous colitis, which can cause raised lesions in the colon, and then they can mimic ulcers. And then you want to treat this, which was updated recently, depending on your test form. It's classically metronidazole and vancomycin, but per the new QBank answers, nowadays it's just straight vancomycin. So use this to your own discretion. And remember, it's oral, not IV or intramuscular. It's oral because you want the antibiotics to hit the colon. So next is pneumocystis jirovecii, which is an opportunistic infection from people who are immunocompromised. So kids who have AIDS or who are on immunosuppressives, they will usually have a dry cough with fever, with diffuse interstitial pulmonary infiltrates, and you want to treat this with TMP SMX. And then there's infectious mono, which is caused by Epstein-Barr virus. It's, the kissing disease, so it's transmitted by saliva. This can present very similarly to strep throat, where they'll have the pharyngitis with the exudates, and they'll also have cervical lymphadenopathy, but usually it's posterior cervical lymphadenopathy, and they might have splenomegaly as well. But the key thing here is the difference between strep throat and mono is that mono has severe malaise. So these kids will be very exhausted and tired. And then you want to treat this supportively because it's a virus. Sometimes people get confused. They may give these kids or teenagers amoxicillin, and this can cause a rash. So if someone had symptoms of a pharyngitis and then they were given amoxicillin and then they develop a rash, that means it was a misdiagnosis and it was most likely that they had mono. And so remember, on peripheral blood smear with mono, you will see atypical lymphocytes. So these lymphocytes will have an abnormally kind of melted look to them. Next is measles. Measles is caused by paramyxovirus. It's also vaccine preventable, but it presents with the 4 C's: cough, coryza, Koplik spots, and conjunctivitis. These are the 4 C's. Coryza just means runny nose. Koplik spots are just these kind of ulcers that are gray-blue on the buccal mucosa, and it causes a rash, a papulomacular rash that starts at the head and descends. This is something that can be compared and contrasted with rubella. Rubella also starts with a rash that starts at the top and goes down, but it does not have the 4 C's, and it has more joint pain instead. So those are the differences. Measles, you treat it with vitamin A. We fear its complications, the 2 main ones, which is pneumonia, and the second one is SSPE, which is subacute sclerosing panencephalitis, and this is a severe brain infection that can happen 10 years later on that will be fatal. And then rubella, you want to treat that supportively. And the dangerous thing about rubella is that if a mom gets rubella, then her kid, the fetus, is at danger for being born with some congenital defects, mainly cardiac defects, cataracts, and deafness. The cardiac defects will be patent ductus arteriosus and pulmonary stenosis. Then there's aspergillus. Aspergillus it's a key lung infection. These questions are often hard to get on question banks because a lot of times they can overlap with a lot of other things. But the main thing here is eosinophilia. So aspergillus will always have eosinophilia, and there's 3 subtypes. There's allergic bronchopulmonary aspergillus, and there is systemic aspergillus, and then there is aspergilloma, which is the fungus ball. So allergic bronchopulmonary aspergillus is something that presents like asthma. So they'll have wheezing, they might have hemoptysis and fever, but the key thing is eosinophilia, and you treat that with steroids. Systemic aspergillus will be hemoptysis, fever, night sweats, weight loss, almost kind of like a TB picture with the hemoptysis, but like I said, it'll have eosinophilia. And then the last one is aspergilloma, which is a fungus ball that you'll see on chest x-ray. It usually is in the upper lobes. Aspergillus likes the upper lobes of the lung. The ones that like the upper lobes of the lung are TB, silicosis, and aspergillus. And then with the fungus ball, this usually likes to grow in pre-existing TB cavitation. Entamoeba histolytica, which is, just remember, right upper quadrant pain with diarrhea. And then this will be treated with metronidazole. And Entamoeba histolytica, usually the vignette will have someone who is traveling in like South America somewhere. Giardia, remember, it's associated with people who go hiking and then they drink contaminated water, and then later on they get these greasy, fatty, bulky stools. So that's kind of the vignette you're looking for, and you also treat that with metronidazole. Then there's malaria. Malaria, look for recent travel to Africa with recurrent fevers. And remember, malaria goes after red blood cells, so they'll have markers of hemolysis, right? Anemia, elevated reticulocyte count, and decreased haptoglobin. And then this is transmitted by the Anopheles mosquito. Usually it's like recurring fevers because certain types of malaria, like Vivax, Ovale, Falciparum, and Malariae, they have different timings where the fevers recycle because that's when the malaria starts to burst out of the red blood cells. There's toxoplasma, and this is associated with cat feces and eating undercooked meat. The mom can have a mono-like illness, but we care because it's one of the congenital torch infections, and the baby will present with chorioretinitis, hydrocephalus, and intracranial calcifications. Then there's Enterobius vermicularis, which is diagnosed by the Scotch tape test on the anus, and you treat this with albendazole. Strongyloides, ancylostoma, and Necator are all hookworms. You step on them, usually through sand contact on bare feet, penetrates, goes into the lungs, and then you cough it up and then swallow it into your GI system, and it invades your GI lumen, and this will cause iron deficiency anemia through slow chronic bleeding. But the key here is eosinophilia as well, and you treat with bendazoles. Then the last parasite is neurocysticercosis, which is infestation of T. solium eggs, and it can cause calcifications in the brain, and it can cause seizures. The next ones we're gonna cover are tick bite. It can transmit 5 different bacteria and cause 5 different diseases. One is Rocky Mountain spotted fever. The second is Ehrlichia. The third is anaplasma. The fourth is Lyme disease. And the fifth is Babesia. So Rocky Mountain spotted fever is caused by Rickettsia rickettsii, and that goes after the vascular endothelium. And then this can cause a rash that starts from the extremities and moves towards the center. That's the key, caused by a tick bite. And it can cause hemorrhaging because the endothelium will get inflamed and dilate. And this can cause anemia, thrombocytopenia, and symptoms of septic shock. Ehrlichia goes after agranulocytes, so those are like the white blood cells, so you'll have decreased white blood cells. Anaplasma also goes for, instead of agranulocytes, goes after granulocytes. Those are basophils, eosinophils, and neutrophils, and this will cause, so look for decreased white blood cell after tick bite. And then look at the differential where they show neutrophils, lymphocytes, monocytes, eosinophils, basophils, whatever's kind of low with respect to the reference, then those are the bacteria you're looking for. But those ones aren't as common. Lyme disease you definitely need to know about, which causes the target rash known as erythema migrans. And then later on, it can cause Bell's palsy or meningitis, or it can cause arthralgias. And then the last one is Babesia. Babesia also goes after red blood cells like malaria, so you'll see evidence of hemolysis. So those are the tick bites. Cat scratch disease, which is a cat scratch can transmit Bartonella henselae, which is a bacteria, and then this can cause inflammation of a lymph node proximal to that along the drainage line. So you'll see like a lymphadenitis proximal to a cat scratch, and you want to treat that with macrolides or doxycycline. TB, remember that you have 2 types of TB, like a latent TB and an active TB. So active TB presents with night sweats, fevers, weight loss with hemoptysis. That will show signs of infection on chest x-ray, and you treat that with the RIPE regimen, rifampin, isoniazid, pyrazinamide, and ethambutol. Whereas latent TB is where when you do a PPD test and there's positive swelling, then you do the chest ray after. If the chest x-ray is normal, then you want to treat that with isoniazid for 9 months. All right, next is cardiology. So in cardiology, remember, if I say fixed split S2, you should think about atrial septal defect. Coarctation of the aorta, you treat it with prostaglandin E because distal to the coarctation, there's not enough blood flow. So you want to keep that patent ductus arterius open to improve blood flow to the lower limbs. Even though that blood flow is hypoxemic, it's better than having not enough blood reach there. So you rather just keep the PDA open. And then you treat that with an excision of the coarctation via surgery or a balloon angioplasty. And it has an excellent prognosis. Remember, this is key too. In a vignette, if the kid was given 100% oxygen test and the PaO2 doesn't rise, then that means it's a congenital heart defect. Whereas if the oxygen does rise up, then that's a lung problem. So if it doesn't correct, that's a heart problem. If it does correct, it's a lung problem. And that helps you narrow your differentials. Then you have transposition of the great vessels. This is when your aorta and pulmonary artery are switched. So out of the right ventricle comes the aorta, and out of the left ventricle comes the pulmonary artery. The only way to fix this is to do an arterial switch operation. And you also want to keep the PDA open for this one as well. The key thing here is it's associated with pregestational diabetes. That's a very high yield association. Tricuspid atresia means that the tricuspid valve doesn't open and doesn't work. So to survive, the baby relies on atrial septal defect to go from right to left. And then when it goes down to the left ventricle, one variant, there's a VSD, and the other variant, there's no VSD. And then this is unique because it's the only cyanotic heart condition that has left ventricular hypertrophy. So if you see a cyanotic congenital heart disease with left ventricular hypertrophy, then this is tricuspid atresia. Remember, transposition of the great vessels, tricuspid atresia, and truncus arteriosus, as well as tetralogy of Foe, have a single S2. Because transposition of the great vessels, the single S2 comes because the aorta is anterior and it drowns out the pulmonic valve, so you hear the aorta more, it's very loud. And then in tricuspid atresia, there's only a single S2 because usually the pulmonic valve is atretic and too weak and doesn't make any noise. Truncus arteriosus has a single S2 because, as you know, for this one, there is no separation between the aorta and pulmonary artery. It's just one giant pipe, so you have a single S2. There isn't two distinct valves. This usually, truncus arteriosus, since there's excess flow to the pulmonary branches, the pulmonary artery and all of its branches, this patient develops pulmonary hypertension very easily. And right in terms of kids who need prophylactic antibiotics for dental surgery, remember, you only give prophylactic antibiotics if they've had some sort of congenital heart disease, if they have prosthetic heart valves, or if they've had previous infective endocarditis. This is a high yield association as well, which is a fetus who has a complete heart block. What is most likely wrong with the mother? The mother most likely has lupus. And then the last one is Tetralogy of Foe. Tetralogy of Foe is characterized by a VSD, pulmonic stenosis, overriding aorta, and right ventricular hypertrophy. And then remember here, the main murmur is actually the pulmonic stenosis murmur and not the VSD. Kids with Tetralogy of Foe can have tet spells, which means when they are crying or exercising, they have decreased systemic vascular resistance. And because there's such low pressure in the aorta, this can favor flow. Instead of going towards the pulmonary artery, it'll go through the path of least resistance and go across to the VSD and then up through the aorta. So this causes right to left shunting, and they will turn blue when they cry or exercise. So to counteract this, they do squatting, and what squatting does is it increases total peripheral resistance, so it increases the pressure over the aorta, and then this favors right-sided blood from the right ventricle will go up to the pulmonary artery instead. So that's kind of the thing you want to know about Tetralogy of Foe. And then you want to correct that surgically. Remember too that any holosystolic murmur or any diastolic murmur is considered pathological. So if you hear a diastolic murmur or any holosystolic murmur, you need to do an echo next. Remember that there's only 3 types of holosystolic murmurs. One is mitral regurg, the second is tricuspid regurgitation, and the third is ventricular septal defect. The most common defect congenitally is a ventricular septal defect. Next is pulmonology. So you need to know the difference between laryngomalacia versus a vascular ring. So laryngomalacia is caused by a collapsed larynx cartilage, and then remember that if you have upper airway obstruction, that causes stridor, whereas a lower airway obstruction causes wheezing. So you need to know what those words mean because that helps you know whether it's upper or lower. So in laryngomalacia, the collapsed larynx cartilage is higher up, so this causes stridor. But laryngomalacia is worsened when supine, when they're laying down on their back, because the collapsed cartilage collapses even more. Whereas a vascular ring, this is caused by an anomaly of the aortic arch where it basically chokes off the trachea and makes a ring around it. and this kid has inspiratory and expiratory stridor, and then this improves with extension of the neck. Then you need to know about croup. So croup is mostly viral and it's caused by para-influenza. They like to ask you what kind of virus is causing it. It can create the steeple sign, but the main thing is clinically they have the barking cough with stridor, and there's 3 tiers of treatment. One is cool mist, the second is steroids, and the third is racemic epinephrine. If there's not many symptoms and there's no stridor at rest and they're not in respiratory distress, then you go with cool mist. If they have stridor at rest but they are in no respiratory distress, then you want to pick systemic steroids. If they have stridor at rest and respiratory distress, then you pick racemic epinephrine. Racemic epinephrine is the high yield answer here that you want to look out for. And then sometimes viral croup can progress to bacterial tracheitis, and then the main bug here is Staph aureus, and this is when croup advances so much that they get a fever and they have a lot of mucus and pus in the trachea. But the main thing for that I want you to remember is if it becomes bacterial, it's Staph aureus. Know what atelectasis means, which is collapse of the lung, which can show up like opacities on chest x-ray, which can look like pneumonia, but it's not. You need to know about bronchiolitis, which is mostly caused by RSV, respiratory syncytial virus, and the key here is the history. So usually the kid starts up with a upper respiratory tract infection, non-specific. So they'll most likely have like a runny nose, a little bit of a cough, and this kid is usually pretty young, like less than 2 years old. And then this progresses to asthma-like kind of presentation with wheezing and tachypnea and sometimes a little bit of crackles. So it can kind of be like a hybrid of like pneumonia and asthma, and the diagnosis is difficult. But on chest x-ray, you'll see hyperinflation with atelectasis, and bronchiolitis is treated supportive. Versus pneumonia, remember pneumonia, the number 1 cause is viral, and this presents with interstitial infiltrates with lymphocytes, because remember, lymphocytes are usually the ones that fight viruses, whereas neutrophils fight bacteria. But if it is bacterial, then you'll see fever with leukocytosis, mostly neutrophil dominant, and then the classic is lobar consolidation. So you'll see a white patch over a certain lobe, and this is more like a more severe symptoms, and you want to treat for which 3 bugs again? Strep pneumo, H. flu, or Moraxella. Sometimes bacteria can also be interstitial, which is on x-ray you'll see interstitial infiltrates bilaterally, and then these ones are mostly caused by Mycoplasma, Chlamydia, or Legionella. Chlamydia pneumonia is like a random zebra pneumonia that you might get a question on, and the key here is just to remember that the buzzword is staccato cough, and there will also be eosinophilia, and you treat that with a macrolide. And then mycoplasma is also treated with a macrolide. Pertussis is also known as the whooping cough. It's the 100-day cough, and the kid will have so much coughing consecutively that they might even vomit after they cough, and they will have been coughing so much that they're basically holding their breath, and then they'll have a whoop afterwards, which is an inspiratory gasp for air, because after coughing 100 times they're out of breath and they're hungry for air. And then this usually has a prodrome for like 2 weeks where they have kind of like non-specific symptoms of like a runny nose and a cough, followed by the whooping stage, and this lasts for months. And then you want to treat this with macrolides. Asthma is the most common pediatric disease, and this is where a kid, whenever they exercise or randomly throughout the day, they'll have episodes of coughing and wheezing and difficulty breathing, but no signs of infection. And on chest ray, it'll show a hyperinflation, because this is an obstructive disease which causes bronchoconstriction of the smooth muscles of the bronchioles, and you want to treat this depending on certain stages. The first line treatment is a beta-2 agonist like albuterol, and as you progress you want to add a low dose steroid, a medium dose steroid, or a high dose steroid. And it depends on how many days of the week they're coughing. So if they just cough intermittently and it's not very often, then you just give a beta agonist. But if it's like 2 to 7 times a week, then you add a low dose steroids. If it's every day, then you add a medium dose steroid. If it's multiple times a day, then you will add a high dose steroid. Last is cystic fibrosis. Cystic fibrosis is, you want to know what are the main culprits. In kids under than 20 years, it's Staph aureus, but in kids greater than 20 years, it's Pseudomonas. And usually, in cystic fibrosis, this is due to the CF mutation, which can cause problems with chloride transport. So the chloride transporter helps add like more liquid to whatever gland that's excreting. So if that's sweat glands, then someone with CF will have really salty sweat because there's not enough water coming out. And this can also affect the lungs. The lungs need to stay lubricated. If there's not enough chloride transport, which water follows, then their lungs will be really sticky and dry and mucousy, and then they're predisposed to lung infections like pneumonia, and they can get repeated bouts of pneumonia, which then leads to bronchiectasis, which is where you have the permanently destroyed, blown up bronchi, and there are no cilia anymore, so they can get repeated infections. And then this can also affect the pancreas, since the pancreas has to release enzymes which need to flow out very smoothly like a juice into the intestine. If the pancreas juices are really sticky and dry, then the kids won't be able to secrete pancreatic lipases. And because of this, lipase breaks down fat-soluble vitamins like vitamin D, E, A, and K, and they won't be able to absorb vitamin D, E, A, and K because lipase isn't making its way out to break these down, so they can get DEAK deficiency. This is a restrictive lung disease. And then you want to just supplement with like pancreatic enzymes and good pulmonary hygiene. Next is GI. Make sure you know that sometimes kids can present with symptoms of asthma, but in reality, it could be GERD. So GERD is gastric esophageal reflux disease, where the acid, when it refluxes up to the lower esophageal sphincter, this can trigger the vagus nerve to cause reflex bronchoconstriction, which causes wheezing. Lads bands are little peritoneal adhesion bands that can squeeze off the duodenum, and this is seen in a midgut volvulus, which can cause acute small bowel obstruction. Midgut volvulus is when, remember during embryology, when the small intestine doesn't twist 270 degrees counterclockwise and it doesn't come back into the abdomen properly, you have malpositioned intestines where basically your cecum is in the right upper quadrant instead, and then this can predispose to a volvulus, which basically means like twisting of the intestine. Think of making like balloon animals. That's basically like a volvulus. And then the kid will present with abdominal pain, nausea, bilious vomiting, because the obstruction is usually distal to the sphincter of Oddi, which secretes bile acids. And then they will have been not passing any gas, not having any bowel movements. And then the first thing you want to do with this is upper GI series, which basically means you get them to swallow contrast fluids and then take an x-ray. And then the x-ray will show that there's a blockage. And then if there is a midgut volvulus, this is an emergency. You want to first treat them supportively with an NG tube to help relieve their vomiting so they don't aspirate. And then you want to get them to the OR immediately to fix the volvulus. Then there's jejunal atresia. Jejunal atresia, look for the triple bubble sign. This is usually caused to vascular accidents in utero. It's mostly associated with maternal cocaine use. And then this should be contrasted with duodenal atresia, which is associated with Down syndrome, which has the double bubble sign. Intussusception. Intussusception is when you get telescoping of the ileum into the cecum, and this can cause inflammation and ischemia of the part that has telescoped. So this kid will have colicky, usually right lower quadrant pain with current jelly stools. The reason why they're current jelly and bloody is because of the mucosal sloughing off of the telescoped part that is now becoming ischemic, and it's colicky. It comes and goes, and the kid will usually try to bend their legs up to their chest, like their knees up to their chest, to get some relief. You want to treat this with like an air enema or an enema with a contrast soluble dye like gastrographin, but don't use barium, because barium, if it leaks out into the peritoneum, it can cause problem. Versus a Meckel's diverticulum. A Meckel's diverticulum it's a diverticulum that has actually ectopic gastric and pancreatic tissue, and then this can cause painless bleeding. So that's the difference between intussusception and Meckel's, is that in Meckel's there's painless bleeding. Then you have your inflammatory bowel diseases. This can be in older kids, like older teenagers, and the two main ones are ulcerative colitis, UC, versus Crohn's disease, and you should be able to compare and contrast the two of these as well. UC always involves the rectum, and it has severe inflammation, but for UC, it's more limited to the mucosal layer, whereas Crohn's is transmural, which means it's full thickness. UC is also associated with toxic megacolon, and also it's associated with primary sclerosing cholangitis of the biliary tree. They're associated with pyoderma gangrenosum, which is one of those ulcers you see on the skin that are white, but they're sterile. So you treat pyoderma gangrenosum with steroids. Necrotizing enterocolitis, just remember this kid can also have rectal bleeding, but it's usually associated with a premature baby who feeds too early. So a premature baby who feeds early and then later has rectal bleeding, this is necrotizing enterocolitis. On x-ray of the abdomen, you might see pneumocystis intestinalis, which means there's air in the intestinal walls. The last that I want to talk about are Crigler-Najjar. So Crigler-Najjar is due to a deficiency in glucuronal transferase. This means that the child does not have any glucuronal transferase, so they are unable to conjugate bilirubin from its unconjugated to conjugated form. So they'll have unconjugated hyperbilirubinemia. How can you diagnose that? Well, hyperbilirubinemia is defined as bilirubin levels above 1. And usually your direct component, if it's above 20%, that's a direct hyperbilirubinemia. But if it's under 20%, then that's an indirect hyperbilirubinemia. Indirect is the same as unconjugated, and direct is the same as conjugated. Remember, conjugated is water soluble, and unconjugated is water insoluble. The unconjugated form can actually pass the blood-brain barrier, and this can cause kernicterus because the bilirubin can actually damage the basal ganglia. Crigler-Najjar causes an unconjugated hyperbilirubin versus Gilbert syndrome, which is, the way I think about it, is like Crigler-Najjar light. This person doesn't have an absolute deficiency of glucuronal transferase. They have a mild deficiency, and it's only visible or apparent when the patient gets sick or they're under stress. Then they might get slight jaundice and unconjugated hyperbilirubinemia, but only when they're sick. And then there's Dubin-Johnson, which is where they are able to conjugate the bilirubin, but they're not able to let it escape out of the hepatocytes. So this person will have a black liver on pathology, and they will have a direct hyperbilirubinemia. Versus Roeder syndrome, which is like Dubin-Johnson, a more mild form, but the liver isn't black. And that's GI. Next is nephrology. So remember, the most common nephrotic syndrome in a kid is minimal change disease. Nephrotic syndrome is defined as proteinuria greater than 3.5 grams a day, or a greater than protein to creatinine ratio of greater than 3.5. That is classified as nephrotic syndrome. Nephrotic syndrome, you're more prone to excreting proteins like albumin. If you excrete albumin, you have decreased intravascular oncotic pressure. This can cause edema and swelling, so they'll have swelling of the face and body. And then also they are more prone to excreting antibodies, and because they excrete antibodies, they get an antibody deficiency, so they're more prone to getting infections. Because they are losing so many proteins as well, there's less oncotic pressure in the blood, so the body will try to compensate by making more coagulation factors and more lipids. So they are prone to getting hyperlipidemia as well as a hypercoagulable state. The most common hypercoagulable manifestation of nephrotic syndrome is renal vein thrombosis. So this kid might have a sudden onset of flank pain, and that is renal vein thrombosis from nephrotic syndrome. The most common nephrotic syndrome is minimal change disease. On histology, you'll see effaced podocytes. So the podocytes will be flattened. They also lose. Remember, podocytes usually have the negative charge, which repels albumin, which is also negatively charged. When it loses that negative charge, albumin can filter through. And you treat minimal change disease with steroids. So remember too, I said infections. This increases their risk of specifically encapsulated organisms. There's a mnemonic for encapsulated organisms, and this is please shine my skis, which is Pseudomonas, Strep pneumo, H. flu, Neisseria, E. coli, Salmonella, Klebsiella, and Group B strep. Kids who also have sickle cell disease, who have gotten splenectomies, are also prone to getting encapsulated organism infections. So remember that association as well. Sickle cell kids or people who have asplenia are prone for encapsulated organism infections. Then there is hemolytic uremic syndrome. This is caused by eating undercooked beef, which leads to infection by enterohemorrhagic E. coli, EHEC, which causes the inflammatory bloody diarrhea. But this can progress to hemolytic uremic syndrome if the kid was given an antibiotic such as a fluoroquinolone. Sometimes doctors will give antibiotics to people with inflammatory diarrheas, especially if they're really young or immunocompromised or really elderly. People in between who are immunocompetent and generally healthy will not be given antibiotics, but EHEC is the exception where if the person is infected with EHEC, you definitely don't want to give fluoroquinolone because this leads to hemolytic uremic syndrome, which is a type of microangiopathic hemolytic anemia. It has a very similar mechanism to TTP, which is known as thrombotic thrombocytopenic purpura, which is the mnemonic is fat RN, fever, anemia, thrombocytopenia, renal problems, and neuro problems. So their platelets basically bunch up, because remember in TTP, this is due to antibodies against Adams TS13. Adams TS13 is an enzyme that breaks down von Willebrand factor. So if you have antibodies against this, then your von Willebrand factor is in excess. This causes increased platelet adhesion. These platelets are everywhere in your circulatory system, and they kind of block off your arteries like spikes. So when the red blood cells try to swim through, they get sheared, and this causes schistocytes. But the schistocytes also cause the red blood cells to hemolyze, so that's where you get the hemolytic anemia. So that's why you get the anemia and the thrombocytopenia, because of the schistocytes. They shear, red blood cells go down, the platelet count goes down because they're all clumped up. And then, so basically HUS is a variant of TTP through a microangiopathic hemolytic anemia, but it doesn't cause fever or neuro problems. And anytime you have any manifestations of uremia, then you want to treat it with dialysis. So the manifestations of uremia will be pericarditis, then that means dialysis, HUS also needs dialysis. Platelet dysfunction also needs dialysis. Next is Alport syndrome. Alport syndrome, I want you to remember hematuria and deafness. If there's hematuria and deafness, the diagnosis is locked in. Pick Alport syndrome. Type 1, which is where you cannot excrete hydrogen, so the hydrogen builds up, that leads to acidosis. That is associated with kidney stones. That's huge. Second one is bicarb, where you cannot absorb bicarb, and because of that, you get acidosis. The trick here is 1 should remind you of H, hydrogen, 1. 2, bicarb, bi, that's 2. So that's, you can't absorb bicarb. And type 4 has number 4, 1, 2, 3, 4. That matches up with aldo. ALDO should remind you of aldosterone. That is hypoaldosterone. So they will have hyperkalemia, hyponatremia, possibly low blood pressure, and this is the only one with hyperkalemia. Those are the 3 RTAs I want you to remember. Posterior urethral valve, this happens in boys. Any boy who was born and still hasn't urinated, you should suspect posterior urethral valve. You diagnose this with a VCUG. Remember that you need to treat this with surgery. And then the posterior urethral valve is since they were a fetus. So the clue here is they can't urinate. If they can't urinate in the amniotic sac, then it's associated with oligohydramnios. The only UTI that has a high urinary pH, 8+, is Proteus. Next is neurology. There's spinal muscular atrophy, which is also known as Wernicke-Hoffmann disease. This is where you get destruction of the lower motor neurons of the anterior horn of the spinal cord, of the gray matter. And then this, because it's lower motor neurons, this will cause hyporeflexia, fasciculations, and like flaccid paralysis. So if you see a kid with that, then it's Wernicke-Hoffmann. But remember, sometimes botulism can present like that too, but botulism, the kid was doing well before and then they got it. Whereas Wernicke-Hoffmann, it's manifested since they were born. With botulism, also, the symptoms go beyond just musculoskeletal. This affects their GI too, and their pupils, their heart rate, their breathing, their sweating, everything. Remember, botulism is caused by the toxin that prevents the release of acetylcholine. So they will have flaccid paralysis. It's usually top-down paralysis. And they'll also have the first sign. What is the first sign? It's because there's no acetylcholine to stimulate the GI, they'll also have constipation. And then also, because they don't have acetylcholine to affect their pupils, then they will also have dilated pupils. And if there's no acetylcholine to act on the heart, then they'll also have tachycardia. But the main thing is flaccid paralysis plus constipation. Think about botulism, you diagnose it with the stool toxin, and you treat it with botulism immunoglobulins. Dandy walker is when the kid doesn't have a cerebellum. This leads to compensation of an enlarged fourth ventricle and blocks flow of CSF. The symptoms of ICP that I want you to remember are headache, nausea, and projectile vomiting. Any kid who has symptoms of increased intracranial pressure, you always want to do a head CT before you do the lumbar puncture to prevent herniation. The only exception is in infants who still have their fontanelles haven't fused yet. Because their fontanelles haven't fused yet, that means that they have excess space to relieve pressure. So with kids who don't have fused fontanelles and you're fearing like meningitis, then you can go straight to lumbar puncture. But if their fontanelles have fused, always do a head CT scan first to find out what's causing the increased ICP. If everything looks good, then you proceed with the lumbar puncture to diagnose meningitis. Tuberous sclerosis is characterized by the mnemonic ash leaf. So ash leaf spots, shagreen patches, heart rhabdomyosarcomas, lung hamartomas, epilepsy, angiomyolipoma, and facial angiofibromas. You treat this with ACTH. Migraine headaches can also happen in kids, and there's the pound criteria: pulsatile, 1-day duration, unilateral, nausea, vomiting, and it's debilitating. It's usually worsened with noises, and being in the quiet and the dark helps a lot. You want to treat this first with Tylenol if you can, but if it's really bad, then you treat with sumatriptan, which is a serotonin agonist. And if they keep getting repeated migraines, you can treat prophylactically with a beta blocker. Guillain-Barré syndrome is, you need to remember, ascending paralysis that's symmetrical, starts in the feet and the fingers and it rises up. The main danger here is that it can cause respiratory paralysis. So the first thing you want to do in someone with Guillain-Barré is check their vital capacity. How much can they breathe? Because if they can't breathe very well, then you might have to intubate them. CSF, this is a unique thing for Guillain-Barré, is it shows cytoalbuminologic dissociation, which means cyto meaning cells, and albumin, there's a dissociation. So there's no cells, like no white blood cells, but there's a lot of albumin. This is a marker for Guillain-Barré. And you want to treat Guillain-Barré with IVIG and plasmapheresis. The plasmapheresis will help take out the antibodies that are attacking your peripheral nervous system. The last is muscular dystrophy. You have Duchenne's muscular dystrophy and Becker's muscular dystrophy. Duchenne's happens a lot earlier, and Becker's, the kid can survive longer into their 20s, whereas Duchenne is more severe early onset. And then this muscle gets replaced with fibroblasts and lipids. This is due to the missing dystrophin in their muscle. And the key thing is hypertrophic calves and the Gower sign, which means they have problems getting up on their own, and they usually have to use their arms to climb up their legs, and this is muscular dystrophy. Remember that cow milk is low in iron and goat milk is low in folate. So if a kid is all he's drinking is cow milk, he can get iron deficiency anemia. If a kid only drinks goat milk, he can get a macrocytic anemia or a megaloblastic anemia. When someone takes iron, make sure to give with vitamin C because it helps increase absorption. Von Willebrand's disease, remember there's a deficiency of von Willebrand, so they will see increased bleeding time because von Willebrand is needed for platelets to stick. And then if the platelets don't stick, that is what measures bleeding time, so that will be increased. And von Willebrand also carries factor 8, which is part of the intrinsic pathway, so they will also see an increased PTT. Spoon-shaped nails is a sign of iron deficiency anemia. This is called koilonychia. Wiskott-Aldrich syndrome should know the mnemonic water, W for Wiskott, A for Aldrich, T for thrombocytopenia, E for eczema, and R for recurrent infections. This is a cytoskeleton abnormality, so remember that mnemonic. Wagger is WWAGR, Wilms tumor, Weidman as in Beckwith-Weidman, aniridia, genitourinary, and retardation. The abdominal masses, you must know the difference between Wilms tumor versus neuroblastoma. So Wilms will not cross, whereas neuroblastoma will cross both sides of the abdomen from right to left. It can be on both sides. And on top of that, neuroblastoma has symptoms of hypercatecholaminemia, which means they'll have hypertension and flushing. So that's what will make the difference between neuroblastoma and Wilms tumor. Sometimes they like to ask you about Vactoril and charge, and might ask you what else is associated with this kid. So if they have like anal atresia, then you have to remember what Vactoril stands for and think that there might be cardiac anomalies, and then the answer might be like echocardiogram. So that's where memorizing Vactoril will help, and charge is the same concept. Hodgkin's and non-Hodgkin lymphoma will often have B symptoms, so that's fever, night sweats, and weight loss. Ewing sarcoma has the onion skinning of the bone with the small round blue cells. Osteosarcoma is a bone cancer as well. Look for the Codman's angle and the sunburst pattern. Osteoid osteoma, look for a lytic bone lesion on the bone cortex. Treatment of rhinitis, runny nose, intranasal steroids. CVID, low antibodies only. SCID, Severe combined immunodeficiency, this is low B cells, low T cells, and low antibodies. And they present similarly with kids who have AIDS, but they don't have AIDS. So they'll have thrush and diarrhea and pneumocystis jirovecii. These kids need monthly IVIG and PCP prophylaxis, and possibly bone marrow transplant as well. Ataxia telangiectasia, ataxia with telangiectasias, the A should remind you of low IgA. Wiskott-Aldrich syndrome, I already told you, water. Bruton, the B should remind you of B cells. They have low B cells, and because they have no B cells, they don't have antibodies either. Treat with IVIG monthly. Chronic granulomatous disease is due to NADPH oxidase deficiency. They have problems with killing bacteria because they don't have their oxidative burst anymore, and because of that, they rely on hydrogen peroxide to kill bacteria. But because of this, they are prone to getting catalase positive bug infections because catalase bugs are able to break down hydrogen peroxide, which is the only weapon that these white blood cells have left. And the catalase positive bugs are, you can think of BASS, BASS, Burkholderia, Aspergillus, Serratia, and Staph aureus. You treat CGD with a bone marrow transplant. Last is Chediac Higashi. It's characterized by albinism and giant granules in the neutrophils. And then last is leukocyte adhesion deficiency. These kids have basically, remember, the umbilical cord has a delayed falling off phase. It takes a while to involute. And also, these kids, the white blood cells have problems extravasating. So they have leukocytosis. The white blood cells will always be in the bloodstream. And then because the white blood cells can't go out into the tissues, they have poor wound healing and they're prone to skin infections. But then if you look at their skin infections, there will be no pus because pus is a sign of white blood cell presence and it won't be there.